hello. I am Dr. Aseshananda Dutta. I am a cardiologist from Calcutta, practicing in presently in ILS Hospital. Today, I will discuss a few lines about hypertension, or you can say a few latest update in hypertension. So, in the introduction, I would like to say that as per WHO, nearly 63% of total deaths in India are due to non-communicable diseases, of which 27 are attributed to CVD, which affects almost 45% of people in the 40 to 69 age group. Raised blood pressure is among the most important risk factors for CVDs. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through primary care, and for poor follow-up. So, in India, the prevalence has also gone up over last 30 years to 38% in men and 32% in women, from 29%, that is from 29 to 38 in male, and 28 to 32 in female. Despite that, nearly half of the people, or almost 51% of men and almost 41% of women with hypertension. Additionally, over 62% of men and more than 53% of the women living with hypertension did not get treatment. Medication was used to control blood pressure in fewer than 1 in 5 men and 1 in 4 women with hypertension worldwide. International Society of Hypertension has released the ISH 20 Global Hypertension Practice Guideline, which there is inclusion of optimal and essential treatment paradigms, attempts to address the issue that in resource poor setting. Optimal care refers to evidence-based standard and refer to minimum standard of care to allow specification of essential standards of care for low resource setting. The AHA-ACC body has released a scientific statement in 2021 offering a new guidance for management of stage 1 hypertension among patients with low ASCVD risk. Among low risk adults, that is no ASCVD or 10-year CVD risk less than 10% with stage 1 hypertension, which means blood pressure between 130 and 139, the systolic one, and 80 to 89, the diastolic one. Management starts with non-pharmacological therapy. If blood pressure remains uncontrolled after 3 to 6 months, then we start considering medicines. Acute respiratory distress syndrome, that is ARDS, is a potentially fatal condition involving lung damage and often associated with severe COVID-19. Nowadays, everyone almost know this about these things. So, a recent study which shows that study appears in the American College of Cardiology journal reports that metoprolol can reduce lung inflammation, improve respiratory function in patient with COVID-19 induced ARDS. Lowering systolic blood pressure targets down to 110 to less than 130 millimeter range substantially reduce cardiovascular adverse events in the step randomized trial, affirming the sprint finding for an older Chinese population. Among some 8,500 patients aged between 60 to 80 in China, the intensive target trimmed 26% of the composite CVDs. Findings from now a second major trial supporting a lower target could unite the guidelines, which even among US professional societies range from threshold of 130 to 150 millimeter mercury. With regard to prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, the 2018 European Guideline on the Management of Arterial Hypertension recommended that the diagnosis of hypertension should not be only dependent on office BP measurement, but also on out of office measurement such as ambulatory blood pressure monitoring or home blood pressure monitoring. 24-hour and nighttime BP measurement were associated with greater risk of mortality and a composite of CV outcome. Thus, they may be considered as the most relevant measurements for estimating CVDs. For every 20 by 10 millimeter mercury increment of BP at night, the risk of mortality increased by 23% and the risk of cardiovascular event by 36%. The 2018 European guidelines equally recommend 5 classes of antihypertensive drugs. Considering high non-adherence treatment, the importance of combination treatment is particularly highlighted to improve adherence to therapy and BP control. Therefore, the 2018 European guideline recommend, especially in the context of lower BP target, to start antihypertensive therapy with an initial dual fixed dose combination of ACI inhibitor or ARB plus calcium channel blocker or diuretic. Since early July 2018, products containing valsartan have been recalled worldwide. The reason is the detection of an unknown carcinogen named NDMA, which can be found in candesartan, irbesartan, losartan, olmesartan, and valsartan. NDMA has been classified by the WHO International Agency for Research on Cancer to be carcinogenic in humans. If 1 lakh patient would have been received NDMA contained valsartan from Zhejiang Huai manufacturing site, where the highest level of contaminants were fired every day for 6 years in the highest dose, it could result in 22 additional liver cancer over the lifetime of this patient. The presence of NDMA in these drugs could lead to 8 additional cancer cases in 1 lakh patients if they had taken highest daily dose for over 4 years. Valsartan recall accompanied by a significant increase in rate of emergency department visit of +6%. The HYGEA study represents the latest study that tested nighttime antihypertensive treatment. In this trial, chronotherapy was associated with a significant reduction in endpoint, including death. So, HYGEA chronotherapy trial tested whether nighttime therapy, in comparison to usual upon awakening hypertension therapy at morning, exerts a favorable CV risk reduction. The largest study included a total of almost 19,000 hypertensive patients. During an average follow-up of almost 6.3 years, almost 1,700 patient participants experienced primary CV outcome. An ambulatory BP measurement was also performed for 48 hours to collect the data on how BP differed during sleep. Relative risk reduction for CV events was also significantly improved for nighttime treatment when compared to awakening morning time daily dosing. This is all for today's update. I hope to meet you soon with further updates in later days. Thank you all.